Great.
See, okay.
Hello, everybody. Welcome. I know it's 4 o'clock right on the dot, so we're going to give a couple of minutes for people to settle in, but we've got a lot of really great content here to share today, so I want to make sure that we get started as soon as possible. Tova, thank you so much for being here.
Yeah, absolutely. Excited to be here.
Great. And then I do know for those of you that are coming in that the chat is apparently disabled, which is pretty standard for, I guess, our recording settings, but you can use the Q&A button that's on your screen. And between Tova and I, we will make sure that we get through and get to as many questions as possible. I try to acknowledge every question that comes in so that you know if I'm going to call on you next, or just that you know that your question's been received, and we are going to work on getting to them. So I'll give it maybe one more minute. Tova, I'll start my introduction and I'll turn it on over to you.
Okay, perfect. Thank you.
Yeah, I'm going to change my name here because as much of a rock star as Ashley is, that is not the name that I go by. There we go. Oh, here we go. We've already got our first question.
Technical question about the webinars of Zoom.
Yes, so the first question came in about if everybody's muted, and so far it seems to be so.
Yeah.
Thank you for asking, Aubrey. Great. All right, well, it's 4:02. I'm going to go ahead and get us started. Welcome, everybody, to the Kids Mental Health Pierce County webinar. It's part of our sponsored event series that we do. That's an ongoing program. I do want to give the disclaimer, of course, that this is recorded because we want to share this great information. So if you want to go back and watch it, if you want to share it with your colleagues or friends, those you serve, it is posted on our website, and I'm going to put a link in our chat. So we're very excited and honored to be having today's webinar focus on supporting the mental health needs of our LGBTQIA+ and gender expansive youth with our very own Tova. Like I said at the beginning, for those of you that are just trickling in, I'm going to be watching the Q&A portion for any questions. So with that, Tova, I'm going to turn it over to you. Thank you so much for being here today.
Awesome. Thank you so much, Gina. And I see, so I'll just give a quick disclaimer. A couple things, I see some familiar names in the participants, so it is good to see some people that have already been in some presentations with me before. This section, and I see a question that I'll just answer really quickly. This section, today we won't be talking explicitly about chronic absenteeism, but we will be talking about what might be leading to some of that chronic absenteeism and what you can do in the school building to support youth who are gender expansive, to support queer youth who are experiencing chronic absenteeism because of what is going on in the school building. Like Gina said, my name is Tova Dinero, and I'm so happy to have all of you here talking about what does it look like to support the mental health of our queer and gender expansive youth. I am an educational and behavioral consultant in Washington State. So I'm based out of Tacoma, Washington. I've done a lot of work with Kids Mental Health Pierce County. I work in over a dozen school districts across Washington State, really in support of trauma-informed practices for our students in grades pre-K all the way up through 12th grade. I work in particular in support of minoritized youth, and I work quite often with youth who are gender expansive or youth who identify as queer. Today's session, we are going to be looking at some of the disparities in mental health. In particular, we will be focusing on gender dysphoria, and we'll be talking about that through the DSM-5 and through the language of the DSM. If that is a new term to you, gender dysphoria, or the term DSM, it's okay. We are going to go into all of it. And we'll also be talking about the evolution of language. We're going to unpack some of the terminology that's out there right now and how society plays a role in that evolution of language. We'll go into trauma and our queer youth. And then we will finish today's session with very specific strategies that you can engage in and incorporate into your work today to support the mental health needs of our LGBTQIA+ youth. If at any time you have a question, please feel free to plug that into the Q&A, and we will be sure to get to it at some point. All right, so we are first going to talk about some of those disparities. We know that the language within the queer community is changing, and we know that we are adding to some of that inclusivity within the queer community. And we continue to see some disparities. We continue to see a lot of disproportionality within the data, in particular of our queer identified youth. So it's really important to recognize that there is a lot of disparities still in mental health, and it's critical to address these and critical to identify what these are. We know that minoritized populations in this country are at higher risk of poor health, of disability, of suicide, and of premature death. Minoritized populations also experience much greater obstacles to obtaining mental health care, right? And this includes our individuals within the queer community, in particular, youth within the queer community. One of the reasons for this disparity is because there is such a long history of anti-LGBTQIA+ bias within healthcare, and this includes mental health care. This continues to shape the access and the health-seeking behaviors for queer individuals, meaning that queer individuals may be less likely to seek out mental health care because of the bias and that they have already experienced. To this day, in Washington State, very close in Tacoma, Washington, where I live, we still see some clinicians continue to harbor anti-LGBTQIA+ attitudes towards individuals. Right? So this is continuing to happen, and this is one of the reasons why people may be less inclined to access mental health care. We'll start to unpack what gender dysphoria is, and the definition of gender dysphoria is a state of severe distress caused by the feeling that one's gender identity does not match one's sex assigned at birth. And so if we'll kind of start to determine what does that actually look like and what does that mean, but it's important that we're all on the same page that this is what gender dysphoria is. Now, the DSM is the Diagnostic and Statistical Manual of Mental Health Disorders. Right now, we are on the 5th edition of the DSM. And this really is the manuscript for every mental health practitioner in the United States. The DSM is what provides criteria for individuals to be clinically met for all mental health illnesses. So if there is a mental health disorder that we have a name for, it is in the DSM. The DSM is how a clinician is providing the diagnosis for an individual. Now, as of right now, as of the most recent DSM, gender dysphoria is listed as a category. And in previous editions, it was called gender identity disorder, but it has since changed to gender dysphoria in the most recent edition. And I should also say that the DSM is changing all the time, right? We are learning new information. We are understanding more and more about mental health illness. And so because of that, we have and we will continue to receive new editions of the DSM. In this most recent edition, gender dysphoria has been looked at and the focus has shifted, where it used to be focused more on the incongruence with the gender identity, so the mismatch that the individual it feels because of gender identity. But now it actually looks at the distress because and the distress about the incongruity, right? And so because of that, because of the change in language within the DSM, gender dysphoria is much less stigmatized now, right? It better characterizes the experience that individuals who are diagnosed with gender dysphoria have. And it's important that we recognize gender dysphoria can be diagnosed in children, in adolescents, and even in adults. There's no age limitation. And in previous DSMs, gender dysphoria, when it was known as gender identity disorder, was actually grouped with other disorders as sexual dysfunction. It is no longer anymore, right? Again, removing some more of that stigma. So now gender dysphoria has its own chapter in the DSM. And it's important to point out that gender identity is self-identified, right? At the age of 2, our children become conscious of the physical differences between boys and girls, the genitalia between boys and girls, right? And using the term boy and girl, I am referring to the sex an individual is assigned at birth. By age 3, most children are able to easily label themselves as either a boy or a girl. Now, what's important about this age is this is also when children become conscious of their societal roles, right? And of societal roles of sex, societal roles of gender in our country. By age 4, most children have a stable sense of their gender identity. So they inherently and intrinsically have a stable sense of their gender identity, but because of their consciousness of societal roles, it can be really challenging to verbalize what they are feeling, right? How that gender identity is manifesting. And so gender dysphoria can be experienced in children as early as age 3 or 4, right? Young children can be experiencing gender dysphoria. And this would look like if they, again, and we'll go into specific criteria, but if they don't identify with the sex that they were assigned at birth. So there are 6 different criterions of gender dysphoria that is listed in the DSM. In order to be diagnosed with gender dysphoria, an individual has to meet at least 2 of these criterions, right? And so, for example, and the 2 pieces of criteria have to be experienced for over 6 months, at least 6 months by an individual, right? So here's the first 3. A marked incongruence between one's experienced and expressed gender and their primary and or secondary sex characteristics, right? So they feel a mismatch between their sex organs. A strong desire to be rid of one's primary or secondary sex characteristics because of this mismatch. A strong desire to have sex characteristics of the other gender. A strong desire to be of the other gender or some alternative of the gender that they were assigned. A strong desire to be treated as the other gender, and or a strong conviction that one has the typical feelings and reactions of the other gender. Now, there's a lot to be said about these different elements, these different pieces of criteria within the DSM, because even in this language, there are societal norms that we have in place, right? For example, number 6, a strong conviction that one has the typical feelings and reactions of the other gender. So right in that, we are assuming that one gender has different feelings and reactions than another gender, right? And so that has some inherent bias, some inherent stereotypes in it. So it's really important to recognize that, again, an individual has to have 2 of these, or has to have manifested 2 of these different elements in order to be diagnosed with gender dysphoria, and it has to cause clinically significant distress. So if we think of some of the youth that we support, clinically significant distress could be refusing to come to school because of their gender dysphoria, significant depression, anxiety, right? Eating disorders come up a lot for individuals experiencing gender dysphoria. Now, many individuals believe that gender dysphoria should not be a part of the DSM because it should not be looked at, and it is not a mental health illness. And I think that that is really important to stress. Due to how our society views gender expansive identities, without a diagnosis, healthcare options and gender affirming support is very minimal in our country. If you are under the age of 18, health options and gender affirming support, in particular through healthcare, is non-existent in our country without this diagnosis. And so there are certain implications of viewing gender dysphoria as a mental illness. And what I'm referring to in that statement is that there's potential benefits of having gender dysphoria in the DSM, right? So having a diagnosis is going to provide better access to treatment. For example, insurance coverage. Insurance companies, every single insurance company needs a diagnosis of gender dysphoria in order for an individual to access any gender affirming surgery or gender affirming care. But with that, there are still many downfalls. There's the stigma of having a diagnosis. This is one of the reasons why schools incorrectly will put a child that is diagnosed with gender dysphoria on a 504 plan or an IEP plan. Students do not need a 504 if they are diagnosed with gender dysphoria. There's also significant discrimination. We see discrimination with a diagnosis of any mental health illness from employers, military, custody issues, court issues with that mental health diagnosis. So although there are benefits, the benefit is really because simply of how our society views gender identity. I want to reiterate that gender dysphoria is not a mental illness. It describes the uneasiness stemming from the mismatch between the experienced gender and the assigned sex at birth. And we'll go into this when we talk about terminology. Gender identity and assigned sex at birth are completely separate. There are, however, unpleasant experiences and potential mental health illnesses that can co-occur with gender dysphoria. And this includes anxiety, depression, eating disorders, PTSD, substance misuse. So we know that when an individual is diagnosed with gender dysphoria, there is a higher likelihood that they will have co-occurring mental health illness with anxiety, depression, eating disorders, PTSD, for example. that comorbidity rate is very high. Now, the good news is that slowly the societal view of gender and sexuality is changing. Just the fact that I am able in Zoom to put in my pronouns now in my name, right? Facebook now has 70 different gender identities you can choose from. So we know that the societal view is changing, and it's slow, but we are moving in the right direction. A couple important pieces of terminology. The first one being gender identity. It is important to recognize that when we talk about gender identity, it's an individual's internal sense of their gender, of being male, female, non-binary, right? Gender identity is internal, it's in our head. It is not visible to others. Transgender is a term for people, for individuals whose gender identity, expression, or behavior is different from that associated with their assigned sex at birth. So again, when we are assigned at childbirth, our sex, which used to be referred to as assigned gender, it's now referred to as assigned sex at birth, the doctor is only looking at our genitalia, right? Our biological sex is what is between our legs and our chromosomes. We also have the term cisgender, which is really important for all of us to know and to understand what that term is. So cisgender is a term used to describe a person whose gender identity, expression, or lived experience aligns with what is typically associated with the sex that they were assigned at birth. So I am a cisgender woman. My gender identity as a female matches the sex that I was assigned at birth. I use the term gender expansive rather than transgender to describe any individual who does not identify as cisgender. And this is simply because every individual defines their identity differently. It is not my responsibility to identify somebody's or define somebody's identity. It's theirs. So gender expansive is the bigger umbrella term that I use to identify different identities. If you need or a little bit more information about this, if this is new to you, the Gender Unicorn is a great resource. It's really helpful to use with youth as well to get any individual at any age comfortable with the difference between gender identity, which again is what is in between our brain. How do I identify myself? Gender expression is how I present myself. My sex assigned at birth is what is between my legs, right? As I am born. Who I am physically attracted to and who I am emotionally attracted to is what is in my heart. So as you can see, all of these are on the spectrum. And that's important for individuals and for youth to recognize. We're going to move into looking at the 2018 Gender Expansive Youth Report, and there's a couple specific data points that I want to address. Only a third of gender expansive youth have families who show support for them by getting involved in the larger LGBTQ and ally community. Only a third. In 2017, we had 150,000 youth ages 13 to 17 that identified as transgender in the United States. And 64% of gender expansive youth say their families make them feel bad for their identities, which is a huge number, 64%. We also know that when gender expansive and LGBTQ youth do not seek affirming support at home, they will seek it from adults elsewhere, in particular, community-based organizations, school systems, classrooms, school counselors, right? That's where all of you come in. How do we validate and affirm the youth that we see every single day? How do we address the mental health needs and make our youth feel like a priority? Only 16% of gender expansive youth feel safe in the classroom. And only 16% of gender expansive youth hear positive messages about LGBTQ plus individuals in school. Right? So again, this goes back to visibility and representation. What types of posters do we have? What types of resources do we have access to? How are we showing our youth whether or not we identify within the queer community? How are we showing our youth that we support them and that we are there for them? What types of messages are we sending? As you can see, and if you've looked at any further data, the Trevor Project has a lot of data on queer youth. It can be pretty depressing and pretty hard to see, right? LGBTQ youth have the highest suicide rates in the country. In particular, LGBTQ youth of color have the highest suicide rates in the country, have the highest homelessness rates in the country or experiencing homelessness. So we know that a lot of queer youth and gender expansive youth experience trauma. And I'll give a quick overview of what this looks like in terms of the brain development of it, right? So on the bottom of the slide of the brain, you see that survival brain. You might call that the reptilian brain. This part of the brain is the first part of our brain to be developed in utero, right? So the moment we are born, if we have a typically developing brain, our survival brain is already developed. It has to be, because the moment that we are born, we are just trying to survive in the world. We then have our emotional brain, the limbic system. This is in the middle, right? It houses the amygdala. The emotional brain does not fully develop until just after puberty. So if you are working with or support or live with middle schoolers, you know what I'm talking about when I say that this part of the brain is firing very rapidly during puberty. That's when it is becoming fully developed. That's why middle schoolers and that, early adolescent age tend to think very much through an emotional lens, which now, if you're an adult, you know that's not always giving you the best bit of information. But our middle schoolers, they are being developmentally appropriate when they are having emotional outbursts, when they are thinking through this emotional lens, because that's the part of the brain that is firing so rapidly to become fully developed. And the last part of our brain to get developed is our prefrontal cortex, right? It's right behind our eyes. The neocortex is that whole part of the brain. It's in blue on the slide, but the prefrontal cortex does not fully develop until we are about 25 to 27 years of age. And that's important to know because that part of the brain is what is responsible for our cognitive thinking. It's responsible for making rational decisions. It's responsible for letting go of fears. for having and understanding what our values are, for making good choices. Now, oftentimes, and if you work with the high school age students or youth, you know that they sometimes like to act like they're an adult, and sometimes adults like to treat them as though they are an adult. But the truth is that this part of the brain that makes us that holistic adult, is not fully developed until our mid to late 20s. And even more importantly, when we are living in our survival brain, and that happens under trauma and toxic stress, we are not accessing that thinking brain whatsoever. The thinking brain physically shuts down so that we can survive. And when we are in survival brain, we are in that fight, flight, freeze, or fawn, the 4 F words. When a youth is experiencing that from as young as possible all the way up through 18 years of age, when they are chronically experiencing survival brain, they are unable to access their thinking brain, which means that it's not going to fully develop the way that a typically developing brain does. And this has huge implications for our gender expansive youth. And we know that youth who identify within the queer community experience significant more trauma than youth that do not identify within the queer community. They experience being called by the wrong name. They experience gender dysphoria by having individuals use the incorrect pronouns, by parents kicking them out, right? By experiencing and using much more substance misuse because of the trauma that they're experiencing at home potentially and at school potentially. We see this in that fight, flight, or freeze, for example, with youth maybe acting out, being defiant, exhibiting hyperactivity. The flight that we often see is that chronic absenteeism, leaving the classroom, sleeping, being completely disengaged, or that just complete freeze over. They're exhibiting numbness. They refuse to respond to adults. They refuse to get their needs met. This might mean that they've stopped showering, right? Stopped engaging in daily hygiene practices. Maybe stopped eating. They feel unable to move or act. When we experience trauma on the brain, so when a gender expansive or LGBTQ youth experiences trauma on the brain, they're going to experience anxiety potentially, some restlessness, maybe lack of motivation or what we would call apathy, memory problems. That's really important to recognize and to acknowledge, is that the part of the brain that's responsible for our memory is the hippocampus. When we are experiencing trauma, which could be that our parents refuse to acknowledge our gender identity, refuse to acknowledge the name and pronouns we want to go by, our hippocampus kicks into overgear and it floods our brain with the stress hormone cortisol. When our brain is flushed with cortisol and essentially becomes hijacked from the stress hormone, the hippocampus is unable to store our memories because its only job is to keep giving us that cortisol. And because of that, it means we might have some short-term and long-term memory issues. When an individual experiences trauma on the brain, they potentially lose the capacity for joy. Experiencing joy becomes much more challenging. We also know that there's impacts on the body, digestive disorders. This is the youth that's always complaining about a stomach ache, altered sleep patterns, insomnia, attempts to self-medicate with substances, maybe engages in self-harm or feels achy all the time. Trauma manifests in our body. So these are some other signs to be looking for, right? Listening for from the youth that you support and work with. And then we know that there is a manifestation of trauma on behavior. Avoidance of activities, social withdrawal, feelings of worthlessness, feelings of shame, right? These all come up for individuals who have or are currently experiencing trauma. Any of the youth that we work with that identify within the LGBTQIA plus community, these are areas to be looking at if we see a change in behavior suddenly. In the United States, trans youth are under attack right now. And you can go to transequality.org to see all of the specific information out there about what's going on. You also can just look at what's happening in the news, because there are headlines happening every single day about what is occurring in our country right now that is impacting transgender youth. In Washington State, we are actually getting more foster youth that identify as transgender because their home states are no longer providing them healthcare access. Right? And Washington State has amazing healthcare access for trans youth or gender expansive youth. And so we're actually seeing that families are choosing to have their children come to Washington State to seek healthcare. Right now, almost 100,000, upwards of 100,000 youth are at risk of being denied access to affirming medical care because of proposed state bans. So this doesn't mean that these bans have happened yet. We know if you look at some of the states, some of them have started occurring. In Washington State, just this January, a new proposed bill, which will be shut down, so we do not have to worry about it, has come out to try to ensure that gender affirming healthcare for youth is illegal, which means people would be criminalized for providing gender affirming healthcare to youth. And that's in Washington State. So there are people in every state across the country that are trying to deny access to support our gender expansive children. And what we know is when we deny this access, we see an increase in suicide. We see an increase in substance misuse, an increase in risky behaviors. So what does that mean for all of us in this session, right? How can we support? What does this look like? There are a lot of different steps that we can take, and I'm going to outline some. But the first thing to remember is that listening, acknowledging, and validating goes so far, right? Acknowledging where the youth is at. It doesn't matter if we agree with them or if we have questions. It doesn't matter. Right now, we validate their feelings and validate their emotions. We do not try to change their mind. The youth know their gender identity better than we do. If you are connected with the family, if you are part of the family, support the participation of family therapy if that is needed, and if that's within your scope to have that conversation with the family. You want to make sure that you are always using the child's chosen name and pronouns with them, and if they give you permission, with other individuals. We know that some youth are not out to everybody, which means that they might not want you to use their chosen name and pronouns with everybody. So make sure that you know who you can use their chosen names and pronouns, their chosen name and pronouns with. And again, if they are in need, support the option of counseling. I'm going to pause right here and look at the Q&A. Oh, thank you. All right, next slide. Also recognizing that we want to provide the space for a youth to explore gender identity and gender expression. That is absolutely okay and healthy. Anytime a child is starting to recognize that maybe they do not identify with the body that they were born in, there's always a social change that happens first. Medical intervention does not happen until later on, until puberty blockers. So it is absolutely okay to allow a youth to explore their gender identity and explore their gender expression. Also thinking about how can we teach and instruct on ways to manage stress? What types of role playing can we do with the youth that we work with? And how can we guide our youth to practice self-acceptance? Words of affirmation go a long way. Reducing the feeling of shame or embarrassment or guilt. Reducing that experience of being on the outside or on the margins of society. You want to support the youth with building a network for them. Who can they go to? Who can they seek out? Who can they receive support from? And also help with communication skills. Maintaining and improving relationships, building new relationships. What does that look like? These are all social emotional competencies that we want all youth to have. And in particular, this helps youth who are gender expansive to support their mental health and in increasing their capacity. It's also important to talk to your youth. Puberty, if any of you remember, is a distressing time. 12 and a half years old is the average age of coming out as transgender or gender expansive. And that's because that is the average age of puberty. Right? So up until then, up until puberty, bodies are relatively androgynous, right? It really starts, gender dysphoria oftentimes starts to manifest because of puberty. So if they're starting to report distress with their body or their gender or their identity, talk with them. What are they feeling like? What does that, what does that feel like inside? How does that make them want to act or behave? It's important for you to understand gender dysphoria. And make sure that you are surrounding them with providers who are affirming and knowledgeable. I cannot speak more highly about Mary Bridge Gender Health Clinic. The providers there are extremely affirming, and they have a list of primary care providers that are supportive and affirming and knowledgeable about gender expansive children, because not every PCP is. You also want to make sure that you are setting realistic timeframes. If you are 10 years old, right, and you are just coming to a gender affirming clinic, there is going to be a time frame for what types of support and healthcare services you're going to access. And so it's important to do your research, and that would go hand in hand with a gender-affirming pediatric clinic, for example, to determine what does this look like. If you are a family member, if you are close with family members of a youth who is gender expansive, it is absolutely okay to be afraid, to be uncomfortable. Keeping your youth from care because of your discomfort is not okay. So get the education from professionals. Early access to care equals better health outcomes. The Mary Bridge Gender Health Clinic, their youngest patient is 4. Now, at that age, there is no medical intervention whatsoever. It is all social intervention. And gender-affirming care, such as puberty blockers or gender-affirming hormone therapy, to reiterate, has been used safely for other individuals and other diagnoses for decades. I know there was a big article that came out in the New York Times a couple months ago that had families worried. And the truth is that those 2 writers did not do their research, right? Or there was a lot of misinformation in that article about puberty blockers. So make sure that you are using reputable sources for your information, and ask questions of doctors. Make sure that doctors are knowledgeable though. So make sure that you're accessing support from doctors such as doctors at Seattle Children's or at Mary Bridge, at their specific gender health clinics. And make sure that you understand how to advocate. For example, getting the right referral. For a child to access support at a pediatric gender health clinic, such as the Mary Bridge Pediatric Gender Health Clinic or the Seattle Children's, you need that child to have a referral for gender dysphoria because of insurance. And that's just the world we live in, the country we live in, the society we live in. Insurance has to see gender dysphoria in order to provide affirming care under insurance. Not every therapist is going to be knowledgeable and affirming. So again, make sure you do your research, and you, if need be, utilize a therapist that actually is an affirming and knowledgeable therapist for the LGBTQ+ community. There's only a couple pediatric clinics in Washington State. There's one in Tacoma, there's one in Seattle, and there's one in Yakima based out of a community clinic. So do your research and see what's going to work for you and for your youth. And it's just important to reiterate that the systems in general have hoops to jump through, but the clinical team is there to help. In all of the pediatric gender health clinics, there's a team with social workers, nurses, doctors, therapists, right? They're there to support. And when you are talking to your youth, make sure that you are taking an open and non-judgmental approach to discussing their history and their experiences. Open-ended questions are really powerful. We want to avoid making assumptions. And this is why asking open-ended questions is powerful, to let them express themselves without us jumping to a conclusion or putting our bias in. And being mindful of the language that we use. So instead of asking, if you work with adults, are you married? Right? Do you have a boyfriend or a girlfriend? Consider, do you have a partner? Are you in a relationship? What do you call your partner? Being really mindful of the language. If you work in a school building, avoid using language like boys and girls, right? Use language like students, scholars, sixth graders, eighth graders. If your school has a mascot, you can use the mascot. Hey, Eagles. Right? Avoid separating youth by gender and avoid labeling youth by what you assume to be their gender, because they're the only ones that can tell you what their gender identity is. And in your work setting, just remember that visibility and representation matter. So create and work to create an environment that is inclusive of LGBTQIA+ individuals. Only 16% of youth in a school have heard positive remarks about LGBTQ individuals. How can we increase that? That can be done in your work setting. Use inclusive intake forms, and I have examples of that for you. And make sure that you display and everybody is aware of the non-discrimination policies within your work setting. That's important. That's a way for individuals to feel safe. We also want to recognize that we should be training all staff members on this work, right? How are we interacting with queer youth? How are we making sure that everybody's on the same page and understands what chosen name and pronouns are and why they're important? What types of brochures, posters, what types of literature do we have that is related to LGBTQIA+ youth, their health, and their social topics? What types of resources are we providing? And what about social inclusiveness and connectedness with family? How can we support that and facilitate that in our role? A family night maybe, where we're getting together and we're bringing youth together, as well as their family, to have a panel discussion and talk about what are the strengths and the weaknesses of our network. What do we have to do to provide more support and resources? Hearing what is needed from the population, from LGBTQ+ youth and their family, is going to be more impactful. Before I wrap up, just a couple things. This is my information, and I do have plenty of time to answer questions if you want to drop anything in the Q&A. Please feel free to send me an email if you have any follow-up questions. And I also wanted to just let you all know, if you do email me, I am happy to also provide the slide deck for you. And there are so many resources. And one in particular that I wanted to bring to your attention is this gender support plan that was created by the Gender Spectrum. And this is something that you can access online. It's just a Microsoft Word document, and it shows you best practice for gender support plans for an individual within a school building or an organization. Any follow-up questions?
Thank you so much, Tova. I always love just the spectrum of information that is covered in your presentations. And we do have a couple of items that got entered to the Q&A. So the first one was actually from Nolan, and there is time to cover questions. So on forms that individuals would be filling out, would gender expansive be a better term than non-binary? Nolan's opposed to the concept of other because of the connotations.
Yeah, so I think, hi Nolan, I think that as of right now, gender expansive would be more appropriate. Although I would suggest that for best practice, I would probably have gender expansive and I would have non-binary, just to have that option.
Great, thank you. Another comment that came from Buffy, where Buffy says, learned through experience that if you have Kaiser insurance, you or parent can self-refer to their gender clinic.
Yes, thank you for bringing that up, Buffy. So Kaiser is the only insurance that if you have Kaiser, they have their own gender clinic within Kaiser. And so you specifically would be going to Kaiser clinics for your gender affirming care or a child's gender affirming care. So thank you for bringing that up.
Wonderful, thank you. And then I see from Sarah, Sarah said, can you put that in the chat? My hunch is that the timing is of your email perhaps, so that they could get the slide deck. Sarah, if there's something specific that you'd like in the chat, go ahead and send another message and I'll make sure that we can get you whatever we can. And then I'm seeing lots of love in here. Lonnie is saying that Tova, you always rock it. Peyton is saying, I saw you present at the Becca conference and again, just really appreciate your information and presentation. I've started using chosen pronoun instead of preferred. Thank you again.
Thanks, Peyton. I'm glad I was at the Becca conference and then tonight I was like, I need to switch stuff up because I do LGBTQ 101 stuff a lot. So as you can see, this was quite a bit different session.
Wonderful. And it looks like we still got a little bit more time. I see some more coming in. Sarah got back to us about referring to the workbook on the previous slide.
Yeah, I can plug that in. Sarah, right before we leave, I will plug that into the chat. And I just want to respond to this one question as well that just came up. How come every time a patient is listed as transgender or gender expansive, they have a mental health issue attached to the diagnosis? Does that harm or help the patient student further down the road? Yeah, so that's twofold. The first part is because gender dysphoria is listed in the DSM, which means that it is technically a mental health illness. That is not best practice to recognize gender dysphoria as a mental health illness, but because of the society we live in, because of our medical care, every individual who identifies as transgender or gender expansive needs a diagnosis of gender dysphoria to receive gender affirming care through insurance. If you're paying out of pocket, sometimes that's different. It depends on the clinic. But with insurance, you need the diagnosis. And absolutely, there is stigma that comes with any mental health diagnosis. The big thing right now in our country and in our society is we need it for youth to receive gender affirming care. And in my opinion, right now, the earlier intervention, the better. We know that earlier intervention provides better outcomes for our children. And so right now that is best practice. And that's why you're going to see it within patient portals and patient protocols.
Great, thank you, Tova. I know we're both keeping an eye on this Q&A. Looks like we got a little more in there from Aubrey.
All right, so yeah, counselors shouldn't write 504s around gender dysphoria. So what are your suggestions for accommodating individuals? Absolutely. So my belief around this, Aubrey, is that because gender dysphoria should not be looked at as a disability, there should not be a 504, that the school should already have explicit protocols to support gender expansive youth. Such as having access to bathrooms, right? Being able to use the locker room of their choice, having access to whatever type of support that you have within a school building, and the harassment, intimidation, bullying protocols, right? So none of these should be additional things that are layered on. These should all be expected systems that are already in place for your students.
Great, thank you. And we might have time for one more if it comes up.
I'm going to drop that gender workbook.
Great. Okay. Well, thank you so much, Tova, again for a really great presentation. We appreciate having you, and thank you for all of you that turned in. We had over 40 attendees that were here today, which is wonderful. So if you have any questions, any follow-up that you'd love to do with Tova, you can see in the chat that we've got the email information there. And as I said at the beginning, we do record these webinars, and it's going to be posted on our website, the Kids Mental Health Pierce County. I've also dropped that in the chat here. So with that, we're right on the dot. Tova, thank you, thank you, thank you. And to
Thank
everybody
you.
else.
And I am, for anybody interested, I am plugging in the slide deck, so you will have access to all of the resources. So I'm just putting it into the chat right now.
Wonderful. And you got a couple more loves in the comments and the Q&A saying thank you and always incredible.
Thank you, everyone.
Thanks, everybody. Have a good night. Take care.